financial interests. Acute acquired comitant esotropia is a type of acquired, non-accommodative esodeviation with sudden onset, often associated with diplopia, but same in all case positions, seen in previously straight-eyed young children, but can occur in older kids, adults, and even in the elderly. Classically, 3 subtypes have been described. Swan type, which occurs after a period of interrupted binocularity. The Beran-Francis type with minimal hypermetropia and double vision, precipitated with physical or psychological stress. The Belchowski's type, seen in myopes with convergent spasm and divergence paralysis. Then the refractive accommodative type, which is previously missed, which can be adequately controlled with refractive correction alone. And the lesser common entity of an intracranial pathology manifesting as an esodeviation, often a posterior fossa lesion. So we know that with the COVID-19 pandemic, with the new norm of work, study and play from home, life has changed tremendously for us. It was estimated that a total of 320 million learners in India transitioned into e-learning, and the global number of workers working from home rose to 558 million. So with the increasing dependence on gadgets for studies, work and leisure, we found a substantial number of kids and young adults coming to the hospital with recent onset of input deviation and double vision, which prompted us to do this study. So this was a retrospective clinical study. Ocular evaluation, including atropine refraction. Ancillary investigations like orthoptic evaluation, imaging, and a neurological workup was also done. So these were our results. We had total 15 cases, 11 males and 4 females. 73.3% presented with double vision and squint, and the mean duration of presentation was 2.98 months. So you can see here the majority about 10 years, with mean age of 16.8 years. Most of them were students, 73.3%, and the rest were employed. There was no precipitating event other than excess near work in most of the patients, except one patient who gave history of fever prior to the onset of esodeviation. So you can see here, majority had more than 8 hours of near work, and the most common medium of near work was smartphones in about 86.3%. The most common activity was online classes in 53.3%, office work in 20%, leisure or mobile games in 20%, and religious text reading in 6.7% patients. So majority in our study were hypermetropes and the rest were myopes. Interestingly, 3 out of the 5 myopes admitted to doing near work without glasses during the pandemic. So if you see the ESO deviation for distance, the average was 22.73% diopters as compared to 18.73% diopters for near. There was good stereopsis for near in most of the patients, though majority had double vision onwards for dot test for distance. So orthoptic evaluation did not yield any concrete results, though it had some discrepancies. So all those with pre-existing or newly detected refractive errors were given glasses, and all those with or at risk of amblyopia advised occlusion therapy. All were advised to restrict and reduce the near work, especially on mobiles. Those with divergence insufficiency esodeviation were given divergence exercises or prisms. The reduction of near work with divergence exercises was helpful in 5 patients, and all those with basic type of deviation, if they were not pre-op and post-op pictures of the patients. So we found 4 categories of patients with AAC in our study. Myopes with divergence insufficiency esodeviation, which could be classified as a Belchowski's type, low hypermetropes with basic type of deviation, low hypermetropes with divergence insufficiency, and a moderate hypermetrope with stress or fever precipitating the esodeviation, which could be classified as Beran-Francis type. Except in the last patient, the only common factor in all other patients was excessive near work either on smartphone, laptop, or books. So when we did a literature search, we found comparable studies by Lee et al., Yanbu et al., and Aldo Vaghe had reported 4 cases of AACE in the COVID-19 lockdown in Italy in 2020. We had earlier reported that in children with AACE, prompt amblyopia therapy and timely surgery can result in satisfactory outcome in those without systemic involvement. So how does this happen? Increasing use of smartphones and tablets in modern life leads to more and more work at small screens at a very close distance. So this leads to an imbalance between accommodation and convergence, and naturally stronger convergence in the young overtakes, leading to a dynamic activation of the medial rectus muscles, development of a manifest esodiation. And this effect is more common in hypermetropes, as was also seen in our study. What about myopes? Now, a myope can also develop esodiation because of the habit of holding books and text close to the eyes. This leads to increased tone of the medial rectus muscle, coupled with a lack of distant stimuli, leading to a divergence weakness and a manifest esodiation. So, continuing school closure, home confinement, and work from home policies has led to many important lifestyle changes in the young population. Another troublesome but lesser known side effect would be this of acute acquired comitant esodiation. To conclude, the habit of long-time sustained near work can increase the risk of AACE, and parents and public health authorities should take note of this serious effect and make suitable recommendations and regulations to mitigate this undesirable effect. Thank you. These would be my references.
Nice presentation, sir. And a lot of work has been done after the COVID, and I think it's a very significant incidence of AACE after COVID. It was a nice work.
Thank you.
Ventrosky was the most commonest, I think, presentation.
Among the myopes, 3 out of 5 myopes were doing near work without glasses because they thought, okay, I mean, everything is near, I can see very well for near, why should I use my glasses? That was, but majority were low hypermetropes in our study.
I have one little question. When we are ruling out the causes of AACE, acute onset, so how do you decide when a neuroimaging has to be done? Do you do it in all patients when they're presenting with an acute onset of esotropia?
Yes, ma'am. That is, if it is not, if I rule out an accommodative component by doing an atropine refraction and giving them glasses, even if it is very low hypermetropia, we do give a trial of glasses and we see if there is any other history of any viral disease or any prodromal disease which would have caused. If it is not there and if it is remaining the same, I do order a neuroimaging because we have previously reported a case of glioma presenting as AACE. So a neuroimaging was done in all, especially if they're fitting into this category of patients.
Have you found a decrease in the incidence since last 6 months?
Yes, yes. So now we are advocating that all of them shift to larger screens, even if they have to do a near work, I mean online classes, go to larger screens, and there has been a reduced incidence. This was maximum in 2020 when we just shifted to the e-learning.